Hello and good morning, everyone, and good afternoon to those of you who are out in the East Coast. My name is Jessica, and I would first like to acknowledge the land I am meeting on today as the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Today, I'm honored to present to you my presentation, Policy Transfer, the Application of Social Prescribing in Ontario based on the UK experience. Over the last 3 months, I was fortunate enough to complete my practicum in Toronto with the Alliance for Healthier Communities, who represent a network of primary care organizations taking leadership in advocacy to advance health equity and advocate for transformative changes in the health system to reduce barriers and improve individual and community health and well-being. And during my practicum, I worked with the wonderful people on research and policy teams to support their social prescribing research project. Social prescribing is the formal practice of connecting people to social programs and non-medical interventions in their community, such as walking groups and knitting circles, to manage non-clinical issues. Social connection has become a significant factor to health and well-being. In 2017, Ontario's Chief Medical Officer of Health reported people with a weak sense of community belonging are more likely to be in the top 5% of users of healthcare services. 5% accounts for more than 50% of total healthcare spending. Social prescribing is regarded as an upstream health promotion strategy where people and communities are empowered to participate and make decisions that impact their health, and where communities become the spaces and provide the necessary conditions to create supportive environments. Interestingly, social prescribing has been taking place in the United Kingdom since the early 90s. And in 2018, the Alliance started their social prescribing project, which transferred this existing practice from the UK to the context of community health centers in Ontario, and it's how my project came to be. So when I started at Alliance, I came into the project in its final phases of data analysis and evaluation. The practices and learnings of social prescribing from the UK had already been taken and implemented in the communities and health centers across Ontario. At the time of planning and implementation, there was no defined course that took into account the factors that come into play when taking policies and programs from one jurisdiction and applying it to another. And it was after the project was well on its way that the research and policy teams began to wonder what considerations should have been made prior to implementing their project. So this led me to my research question: what factors do policymakers need to consider when transferring a public health policy or program from one jurisdiction to another, which can be described through a process called policy transfer. So policy transfer public health increasingly emphasizes the importance of making evidence-informed decisions, which calls for finding, using, and sharing what works in public health or shows the potential to work. And this is the essence of a concept called policy transfer. Policy transfer is a dynamic process where knowledge and evidence about policies and programs in one jurisdiction is used in the development of policies and programs in another jurisdiction. So policy transfer and evidence-informed policymaking share many underlying principles, particularly as they relate to empirical data, experience, and tangible outcomes. While both evidence decision-making and policy transfer are not new concepts in their own respect, bridging these two ideas made policy transfer a practical option for further exploration in my project to advance public health objectives. So to answer my research question, task was to conduct a literature review, and my deliverable was organizing this information in a meaningful and relevant way in the form of a briefing note that would provide additional recommendations to help further scale this project in Ontario and across Canada. The process of my review started off with using the spider tool to organize an effective search strategy which established inclusion and exclusion criteria. The articles found and included in my report were subject to a title and abstract review and a full text review. And as seen on the diagram to the right, in total, 126 articles were identified, but only 16 were included in the review. So for policy transfer of public health policies and programs to be successful, 4 main considerations were identified in the literature that policy and decision makers must look at. And because the Alliance's project was essentially complete, I was able to then take a retrospective to see if these factors appeared in the Alliance's social prescribing project. The first factor is the historical policy landscape and policy success, which looks within a jurisdiction's own past experiences with a particular policy or program and the past experiences of other jurisdictions. If there have been successes or challenges with previously implemented policies, policymakers may either view this as evidence to deter policy transfer or an opportunity to learn what has or has not worked in the past and what not to repeat moving forward. In the Alliance of Social Prescribing project, this is the first of its kind in Canada to use this approach to address the physical, social, and economic conditions that impact individual and community well-being. Evidence from the UK is beginning to demonstrate the positive impacts of social prescribing on people's overall health and well-being, particularly those in marginalized communities, and has shown to decrease the use of healthcare services and hospital emergency admissions. This potential for social prescribing's greater impact has resulted in the National Health Service in England adding social prescribing to its long-term plan and investing in the infrastructure necessary to implement social prescribing across the country. Considering this evidence from the UK and observing the success with social prescribing as well as their long-term commitment to the approach, made social prescribing a recognizable program for the Alliance to transfer. Next is the policy arena. So policy transfer is a multidisciplinary process that engages many stakeholders who can influence the transfer process from local, national, and international areas. Transfer success greatly hinges on having the right policy actors involved and having consensus between what is called soft transfer and hard transfer. Soft transfer involves the transfer of broad policy ideas, often led by policy transfer entrepreneurs such as universities and think tanks. And hard transfer involves transforming policy ideas into practice, such as government officials enacting legislation and regulations. Coordinated and collaborative efforts are necessary in order to enhance the receptiveness of evidence, which improves policy transfer success. The stakeholders involved in the Alliance's policy transfer exercise ranged from local to international domains, including the Community Health Centre pilot sites, the Director of Personalised Care at the National Health Service in England, and Ontario's Ministry of Health. One community health center specifically brought this idea of social prescribing from the UK to their small community, and in collaboration with the Alliance, they further transformed this idea into practice by implementing it in primary care delivery across the project pilot sites. So by engaging the Ministry of Health, the goal is to add another layer of hard transfer by adding this program to the scope of Ontario health teams. Next, the process of policy transfer must also interact and coexist with the already existing social and cultural dynamic within a jurisdiction. Policymakers must not only acknowledge their similarities with other jurisdictions, but also understand the significance of their differences and the implications that policies and programs will have on community issues in local settings. And finally, policy transfer can be challenged if bureaucratic structures between original and adopting jurisdictions are not closely aligned. Issues pertaining to public health and the process of transferring policies or programs yield better outcomes when led by a jurisdiction's Ministry of Health. When the same institutional forces are involved in the policy transfer process from both the original and adopting jurisdictions, policy and program objectives are easier to interpret and apply because the policy implications for both institutions will likely be similar. Policy transfer is also highly influenced by the partisan ideas and beliefs of politicians and decision makers. This ideology affects the decision makers' goals and how they intend to achieve them, including the policies and programs they may choose to transfer. When jurisdictions share similar ideologies and political objectives, they increase the prospect that policy actors from the adopting jurisdiction will look to their counterparts for ideas, knowledge, and expertise. Canada and the UK are connected by their shared constitutional history, which has resulted in similar social dynamics, cultural traditions, and political systems. In these jurisdictions, health is viewed more than a treatment of a medical diagnosis. Individuals today are seeking power to actively engage in their health, and this includes looking for an approach that looks for opportunities to demedicalize certain areas and increase client capacity in order for people to better manage their own health. In this case study, both jurisdictions' health sectors were involved in the policy transfer process. Additionally, the UK has incorporated social prescribing in their universal personalised care model through their integrated care system, and this makes it likely transferable to the Ontario Health Team's model as well. These shared dynamics, traditions, and political systems made policy transfer of social prescribing between the two jurisdictions a logical occurrence. So community health issues such as homelessness and poverty can be convoluted and perplexing with no clear-cut definitions, no precise solutions, and where each issue is inevitably linked with another. In this regard, policy transfer can impact public health practice, particularly as an additional approach to address these wicked problems. With the increase in globalization, wicked problems in public health emerge as common issues that are prevalent in many regions of the world. And these common issues lead many jurisdictions to find and share evidence of effective and successful policy solutions, naturally making policy and decision-making transnational processes. So that concludes my presentation. I just wanted to take a moment to thank the Alliance for Healthier Communities and my supervisors, Jen, Sarah, Kate, and Sonia, for their support and guidance throughout my practicum experience, and to Victoria Barr, and for the University of Victoria School of Public Health and Social Policy in the last 3 years. Thank you.
Thank you so much, Jessica. So are there any very, very interesting talk? Oh, there's already a question. Chantel, go ahead and ask your question.
Hi, Jessica. Thanks for the presentation. That was really interesting. I'm just wondering, what are some of the challenges to transferring social prescribing from the UK to Ontario?
So I think one of the main challenges that I heard of when I was asking my supervisors about what the process was like when they were doing the planning implementation was, so in the UK, there are two models in which social prescribing can be implemented. So there's a model where clinicians in a network refer patients to a staff member called a link worker. And this link worker is a person who then follows up with the patient, and they go through a thorough assessment in terms of their social needs. And then that link worker will then refer the client to different social programs in the community that are available for the client to attend. And then the other model is a peer leadership model where clients are trained and volunteer to run programs. So when the Alliance brought social prescribing to Ontario, the pilot sites were given the option to either choose one or the other in terms of the model they were going to use. But while they were moving on with the project, they realized that it was actually a combination of the two models that was actually the most effective for all the pilot sites. So in the end, they ended up merging the two models from the UK. So if there was that consideration perhaps beforehand in terms of like the social and cultural context of the CHCs or the community health centers in Ontario, that step in terms of choosing one or the other model and then having to switch halfway or switch partway through to then merge the two models, that could have been reduced or could have been prevented.
Thank you. Just one quick question from Sanjeet before we move on to our next speaker. So Sanjeet, go ahead and ask your question.
Perfect. That was great, Jessica. I'm quite interested in this program. So are there any plans to transfer this program to other provinces or territories?
So at the time when we were releasing our final report, there were some talks, and so there were only 11 pilot community health center sites. So there was already some momentum in terms of implementing social prescribing to other community health centers in Ontario, and some talks to doing some family health teams as well. I think there is some consideration, but at this time, it's all kind of up in the air because everything's had been put on pause because of COVID. So we'll just have to wait and see.